because, as you know, a preeclamptic patient is already depleted of her intravascular space. So a diuretic is just going to exacerbate this problem. Again, it's always a risk and a benefit. So when we say never, you have to always consider your resources and what is surrounded by you. But you should always be aware that if you decide to give a diuretic to a preeclamptic woman or to a pregnant woman, you're decreasing their intravascular space, don't forget. Now, what about beta-adrenergic antagonists? They function by decreasing the cardiac output and interfering with renin release. This increases the frequency of intrauterine growth restriction. So mostly this was studied in women who took atenolol, which crosses the placenta more readily. That being said, we know that labetalol is safe, but labetalol works differently. And here I have this slide on labetalol. It works both by an alpha and a beta-adrenergic antagonist activity, and that's why it's different from just the beta antagonist. So it's commonly used for acute treatment of preeclampsia and therapy for chronic hypertension. There has not been an identification of its association with teratogens, so it's a very good choice if you have it available. Hydralazine. So hydralazine's a diuretic. So the side effects are headache, palpitations, due to the reflex increase in cardiac output. And it can also cause tachyphylaxis, which is a rapid decrease in the response to a drug due to previous long-term exposure. So I want to correct one thing I said. Hydralazine is not a diuretic, excuse me. But it's good to know that hydralazine has these side effects, but it's very good use to short-term blood pressure control. Methyldopa is the only drug whose safety for infants has been demonstrated in long-range follow-up assessments. It's a benchmark of antihypertensive therapy in pregnancy, but its side effects are drowsiness. ACE inhibitors are considered a category X, meaning they're contraindicated because of the renal agenesis, meaning affecting the embryologic formation of kidneys, and neonatal renal dysfunction. With ARBs, there's less experience, but they really should be discontinued before pregnancy or as soon as a pregnancy is detected. So choice of drugs, you should, if a patient comes to you and they're already on a medication, it's best to continue. However, it depends what they're on. For instance, if they're already on atenolol, you can switch to, well, labetalol would be better, but you could even switch to metoprolol because we know that atenolol passes through the placenta faster. So suppose you have a patient who's on diuretics because maybe they have kidney failure. Although it's not recommended in pregnancy, and we know it's related to intrauterine growth restriction, you have to consider the risk-benefit, because naturally your patient who is on dialysis, hopefully is really thinking about their risks anyways by getting pregnant, but this is somebody who you may not want to totally discontinue their diuretic, but maybe lower the dose perhaps, or add another drug to control the blood pressure. So these are the different doses of methyldopa, labetalol, and nifedipine that you can look at. And you should always consult a cardiologist or a nephrologist if you need more than 3 agents, or if you need 3 agents of medications. So here we have an algorithm for treatment. So you really want to treat somebody, or at least, and it doesn't have to always be medication. It can be modifications in their lifestyle. But if their blood pressure is a systolic above 140 or the diastolic above 90, then you have to ask yourself, is there any end organ involvement? If the answer is yes, then you need to give them medication. If the answer is no, then you need to look further for whether they need medication or just some adjustments in their lifestyle. And I'm only talking in pregnancy, don't forget. So if the systolic blood pressure is above 160 or the diastolic blood pressure is above or equal to 105, the recommendation is to start medication. And these recommendations, remember, are from the American College of OBGYN. And so you may come across different recommendations from different countries. But what I'm presenting today is just from where I come from, which is the US. Keep that in mind. Now, going further on the obstetric management of hypertension, recognize superimposed preeclampsia early, monitor the fetal well-being. So there are different ways of monitoring the fetal well-being. Where I come from, a patient with chronic hypertension starts fetal testing at 32 weeks of gestation. And what this means is that twice weekly they come in to our fetal testing unit where they get a non-stress test twice a week and a biophysical profile once a week. In your setting, think of ways that you can follow the fetal well-being.